Hi, everyone. This is Katie Buckholtz, and I am being assisted by Laura Waltz. Thank you guys so much for attending the Clinical Quality Experts Decoding the Cost category. So what we will do is we will begin just by going through these slides. The slides and the recording will be available to all attendees, and we'll give you more information about that as we continue. All right, so just going to give a little bit of a brief overview of our speakers. As you see here, I'm Katie Buckholtz. I've worked with hundreds of clinicians across the US. I have a clinical background in ophthalmology and optometry, and I've had previous experience managing my former practice's participation in meaningful use, PQRS, and the previous MACRA programs. And Laura Waltz is our Director of Clinical Quality Experts. She has a ton of experience working in healthcare, both clinical and on the software side. And she's definitely an expert in compliance support for CMS programs, starting from meaningful use to present day MACRA. All right, so for today's agenda, we're going to try to keep you all awake here. The cost category can be a little bit mind-numbing, but we'll do our best to keep you awake. So we're going to go over with the cost category measure basics. What is it? Measure types, common features, terms you should know. We'll also start into understanding the measures. So there's 3 separate areas here in the cost category, and we'll go into those. We'll look at fun things called risk windows, attribution, scoring basics, cost measure influencers, and then we're going to put all of this together with a case study and tips and tricks. And then you'll be relieved to hear us with our closing remarks at the end, no doubt. All right. Now, the cost category. The cost category basically started off as a category that didn't contribute much to your final score. According to Congress, we will eventually have the cost category equal in weight to the quality category. So basically your registry category for MIPS will have an equal weight with the cost category. So as we're looking at the cost category, we have the different measure types. We have the total patient cost per capita. We also have the MSPB, which is our Medicare spending per beneficiary clinician. So as you see, we have a ton of acronyms, of course. We're also going to look at the episode-based cost measures. Now, for the majority of our audience, which are ophthalmology and optometry, this is going to be where you'll want to definitely pay attention because the cataract episodic cost measure falls into this category. As you see here, we're going to go into terms. That's going to be just basically a list of vocabulary terms that when you have the slide deck, you'll be able to go back and research and look up the different terms just in case you need a refresher. And we're also going to go over to some common features. All right, so cost category. This one is one of our 4 performance categories of traditional MIPS. It's the old value-based modifier program. So if you go back in the day, that's what this category is. And what it does is it measures the Medicare payments made for care provided to patients. Now you might be thinking, okay, well, the fees are basically set by CMS. And while that is true, CMS is watching what else gets coded in the process. So now, as you know, with your other categories, you have reports, you have registries, you have your own tracking mechanism that you can see throughout the year. The cost category is a bit of an anomaly on this one. So it's based on claims data. So whenever you send in a claim, that's what CMS will track for implementation into the cost category. So CMS does not provide an active dashboard that tells you how you're doing. You end up seeing how you do basically when the final scores are released about half a year after the performance year ends. So we really have to take a proactive approach to looking at this category, because there is such a delay in the data that's available. All right. So as you see, measures that are used to evaluate performance. We have our TPCC, we have our MSPB clinician, and we have our episode-based measures. So TPCC is a focus on the primary care docs. The MSPB clinician is a focus on inpatient hospital stays, and episode-based is focused on the specialty physician. So the total purpose of all of this, what's the total purpose? It's to drive down costs by incentivizing total patient care and shifts the focus from volume to quality. All right, so we see this little math application here. Cost-effective care plus efficient use of Medicare resources equals your reward. All right, moving on. So here are the basics for our cost measures. TPCC, as you see here, it's the overall cost of care to the patient, and it has the primary care focus. Now, in order to qualify for this, there has to be a 20 Medicare patient minimum. And then this measure is specialty adjusted. That began in 2020. Is the addition of the specialty adjustment. So that way, that way a specialist wouldn't be attributed what should be attributed to primary care physicians. We'll go into that a little later. The next part is the MSPB. This one assesses the cost to Medicare for services to the patient, and it's a focus on your inpatient hospital stays. Now you get a 35 episode minimum for this one. And then our final one is the episode-based. And this is related to initial treatment of the patient for a specific clinical event. For example, standard cataract surgery. It looks at hospitalizations and procedures. There's a 20 acute inpatient episode minimum and a 10 procedural episode minimum. So this is basically looking at the who and what's eligible. And so we're starting to now look into the rule book of the cost game for CMS. And then what we'll do is I will turn the next slide here over to the clinical director of CQE, Laura Waltz.
Yes, thank you, Katie. My apologies, I was having some technical issues. So before we move on to the more detailed explanation of the measures, we can review some important terms that you'll hear throughout the presentation today. Some of these terms you may be familiar with, but there are a few that are not commonly known. So we begin with the term beneficiary, which is used to identify the patient with Medicare Part A and B. And this term ties in with beneficiary months and beneficiary month attribution. The beneficiary month, it is used in the TPCC category to compartmentalize months that fall within the risk window for a beneficiary. Then each month is 4 weeks long, and there are 13 months in a risk window. The care that happens within that month gets attributed to the TIN and or the TIN NPI based on who provided the plurality of candidate events. We'll get more into plurality in just a minute. So candidate events is also used by TPCC and is used to indicate the start of the primary care relationship between the patient and the clinician. The candidate event opens the risk window when the combination of qualifying services occurs, and there can be multiple candidate events within the performance year. The term cohort is used by episodic measures to identify a patient group. when they undergo procedures or receive a treatment for one of the episode measures. So it's a way to identify patients undergoing a similar treatment. Then the measurement period, that is a misleading term. It's basically just the calendar year, but can also be thought of as the MIPS performance year. Next, we have the Medicare Severity Diagnosis Related Group, MSDRG. This group classification system is based off of groups which are made by separating the ICD diagnoses into different body systems. And there are 20+ body systems with about 450 subgroups. And the fees are assessed by factoring the body system and group affected and hospital resources required to treat that type of condition. And this is used by the MSPB measure. Next slide, please. So next is plurality, a term which designates the TIN or the TIN NPI that holds the majority of candidate events open during a risk window. Again, mainly used by TPCC. When you hear the word plurality, just think of it equals majority. And in another case of cost measures, primary care services is a term used for the specific E&M primary care services that qualify to open a candidate event. And then we have risk adjusters. You may already be familiar with those with other claims, but they are those risk factors that affect medical costs regardless of what type of care is given to that patient. So in other words, patients that may be harder to treat, but the difficulty is not based on the direct condition being treated, that's going to be adjusted for risk. And then the modes are based on a patient's Medicare medical history, their care settings, such as if they are in a long-term care hospital or inpatient setting, and then whether the patient is in end-stage renal disease and or using dialysis. We've mentioned risk windows, but again, it describes that year-long period opened by the qualifying candidate event, and that risk window is separated into 13 beneficiary months. We have service category exclusions, specialty exclusions, and service assignments, which are fairly straightforward, and you can see those descriptions. So we're going to go ahead and move into Windsorizing, which is an averaging method that removes the smallest and largest values from the data set so that the skewing effects of extreme values are reduced. Next slide. So each of the measure categories are very neat, but there are some features that are shared among them. So these include payment standardization, which is basically the Medicare allowed amount, taking differences into cost into consideration. Those costs are based on labor and practice expenses in specific regions. And then those regions that qualify for extra Medicare payments because they are in regions that are medically underserved, and then they also adjust for teaching hospitals. Each measure also uses national benchmarks, which are based on data from a performance period versus a historical baseline period. And it is important to note that benchmarks are created after the performance period. You have attribution, which assigns the Medicare beneficiary that cost of care to a specific clinician assigned at the TIN and the TIN NPI level. And the attribution method is specific to the measures. And finally, we have that risk adjustment, which takes your clinical risk factors, comorbidity, and other factors influencing that clinician's spending into account so that that clinician does not get penalized for any spending that is not in their control. So here we are going to go ahead and break for our first poll question. Next slide, please take a moment to go ahead and submit your answer. Okay, next slide. So thank you for your participation in our poll, and we'll move forward now. In this next segment, we are going to take a closer look at our measures. So first is the TPCC, the total per capita cost. We'll go over MPSB, episodic. Also going to talk about the risk windows and a deeper dive into attributions. Next slide. Okay, so the TPCC, or total per capita cost, measures the overall cost of care with the focus on the primary care, which has a 20 case minimum. And this measure, again, focuses on overall cost of care, and it focuses on the primary care, but it can also involve non-exempt specialties. The measure numerator counts the sum of the costs remaining after all of the adjustments for risk and specialty are done, and also after payment standardization has been performed for all of the beneficiary months that occur in the denominator. So the number of a beneficiary month in the denominator can range from 1 to 13, depending on where the episode is falling, or the event is falling within the performance year. So that is because Medicare segments the 52 weeks in a year into 4-week blocks. So that is why there are 13 of them. So the data for this measure is drawn from the list of sources that you can see here. The claims data itself is, of course, brought into the count, and then you have other information for beneficiary enrollment in the enrollment database, and also the common Medicare environment, which also involves the beneficiary enrollment and demographic data. You have your long-term care minimum data set, which is screening assessment tool that is used for residents of long-term care nursing facilities. And then the provider enrollment chain and ownership system, or PECOS, manages actual provider enrollment and supplier enrollment. So all of these tools together provide the data for the measures. So you will see that these data sources repeated to various degrees in the other measures as we go over them. However, TPCC uses the most sources in their data collection. Next slide. So TPCC bases its adjustments on candidate event exclusions, which fall into different categories, the beneficiary exclusions, specialty, and also service category exclusions. Of course, beneficiary related to patients themselves, but these are exclusions that are not based on patient health. These are patients that are not enrolled in Medicare A and B for every month of the measurement period, patients that get enrolled into a private Medicare health plan, and also excludes them those patients that reside outside of the US during the measurement period, or if they are covered by the Railroad Retirement Board. On the clinician level exclusions, TPCC excludes for those that provide non-primary care services, such as general surgery, and also clinicians that practice specialties that do not involve primary care services usually. However, it is very important to note that even if you are a specialist, you may not be on the exclusion list. So, for example, dermatologists still can come under this TPCC category. And there is a list of 56 different specialties that are excluded, and the complete list can be found in the measure resources, and we do provide a link for that later on in the webinar. That list does change from year to year, so it's important to keep current as to whether or not, if you are a specialist, if it's going to fall into that exclusion designation. And then there are also service category exclusions that are used for clinicians that meet a billing threshold in the service categories that you see listed here. And should your clinician reach any of these category exclusions, they will not be calculated for the TPCC measure. Next slide. And our next measure is the Medicare spending per beneficiary, or MSPB clinician. This has a 35 episode minimum and is concerned with the cost of Medicare services for patients in the hospital who have a hospital stay or admission, and they take into account what happens with the services prior to, during, and then after this day. Where the TPCC measures uses events, this measure calculates by episodes to describe their cases. So once an eligible admission occurs, the episode is considered to be the 3-day prior to that admission, and then continues on until the last 30 days after their patient's discharge. These episodes are medical or surgical and get attributed at 10 or 10 NPI levels. The denominator is all the episodes that are attributed to the clinician or group during the performance year. To get the numerator, the CMS sums the ratio of actual to expected costs after payment standardization, but basically all of it means that CMS takes what is spent over what they expected something to cost to make the calculation. And next slide. The exclusions are listed here, and they may look the same at first as TPCC, but there are definitely differences. Patient have to be enrolled with a Medicare A&B for 90 days before the episodes start and 30 days after discharge, and again, cannot be enrolled with private Medicare plan or having Medicare as a secondary payer for any time during that episode or for the 90-day look-back period. The look-back period is used to ensure enrollment of the patient and then evaluating any pre-existing conditions that may affect the episode's eligibility. Then there are no specialty exclusions, but if there has not been a main clinician attributed to the episode, then it gets dropped out of the calculation. So then the service category exclusions serve to remove those unrelated services from the measure. And then there are other exclusions based on inpatient admission criteria or the type of hospital involved. So any episodes that fit into any of these exclusions get removed out of the measure calculation. Next slide. Our last cost measure category is the episode-based measure, and there are two different subcategories in this measure. They are procedural episode-based measures, assessing cost for care related to initial treatment of a patient for a clinical event, and then also the acute inpatient medical condition episode-based measure. That deals with hospitalizations and or their procedures. This is different from the other cost measures because those measures are looking at overall cost for over a specific time period, but episode measures look at costs related to items and services during specific episodes. There are 13 procedural measures and 5 acute inpatient measures, and they both have different minimum data requirements to report the overall measure, but 20 are needed for the episodic and 5 are needed for the acute inpatient. Wave 3 of this category, which will come up in the future, is going to have a third category of measures for chronic conditions such as asthma and diabetes, but these have not been released yet. You can refer to the specific measure details in the cost measure information forms. Again, links will be provided. Next slide. So here we have some general exclusions for each measure group that refer to all episodic measures, and they differ in small but critical ways from the other exclusions we have discussed already. So in the interest of time, I'm not going to go into great detail, but I do want to point out that in addition to these general exclusions that exist for episodic measures, each particular measure has its own set of exclusions. And again, you have to refer to measure details to get that information. Next slide. So there are a few other areas I want to go over before handing things back to Katie, and one is risk windows. But before we talk about them, it is important to understand how and for how long an event or episode window stays open to comprehend how a measure calculation works. So TPCC is the only measure that uses an actual risk window verbiage to measure time, but since it is a bit confusing, that's what we're going to go over. But both MSPB and episode-based measures use the term episodes to identify a cost incident that could be included in the measure count. Next slide. Okay, so we're going to talk about risk windows now, and to begin, we need to know that the measurement period in TPCC is the performance year, starting from January 1st to December 31st. And in our first example here, we have one clinician that practices under 110, and this clinician sees a patient. The patient is not seen by any other clinician during the performance year. The clinician bills with the primary E&M code and then a secondary primary care service code, which is outlined by the TPCC requirements, and they do need both of those billing instances in order to open the risk window. So when that happens, the risk window is open for a full year, which is broken down into the 13 4-week-long beneficiary months indicated by each of these blocks. So all costs that are incurred by Medicare during the open risk window for this event gets monitored and used in the calculation of the overall measure score. So in this example, because the patient did not see any other clinician during the risk window, all beneficiary months will be attributed, meaning credited, to the clinician. So this is a very simple example of one clinician, one patient that falls entirely within their performance year, but we all know that things are not that simple most of the time. So let's add in a few variables. Next slide. So in our next example, we will see what happens when there are multiple events. So our clinician sees the same patient for a yearly exam, and the patient always makes their appointment for some time in mid-year. So that means that the risk window is overlapping performance years. So when this happens, the beneficiary months are split up into different performance years, and the cost for those months are attributed to the performance year that they fall under. For candidate event 1, months 1 through 5 go to the previous performance year, and the rest to the current performance year. Now the patient comes in for their next yearly exam in the current performance year. So this clinician opens up a second candidate event, and that event won't actually end until next year. So beneficiary months 1 through 9 will attribute to the current year, and the rest will be monitored for calculation and attribution for next year. And both of these candidate events would be attributed to the same clinician based on no other events or plurality happening. But again, in this example, we are working with one patient and one clinician and one TIN. So let's take it even further. Next slide. So we've been dealing with the attribution all along, but it has been pretty simple since we had the one doctor in our example. Now let's say that instead of seeing the same clinician, the patient needs to switch to a different practice. So we start with the same setup as before, where the doctor is with TIN A, sees the patient and opens a risk window. That risk window overlaps into the current year. Now, instead of going back to that same doctor, the patient has to go to a different practice. So a new candidate is billed under a new TIN and the risk window opens. That is overlapping the first window by 4 months. So in this example, TIN A and TIN B have an equal number of candidate events in the performance year, and so neither one of them can claim any plurality, meaning the majority, and so they will both get attributed. Next slide. But what happens if that is not an even split? So let's say that the patient stayed with their first doctor for their annual exam. Now we have a TIN A opening 2 risk windows as we saw previously. However, that patient needs to go see another doctor during the performance year, and TIN B bills for a candidate event and opens a risk window too. So now we're going to see plurality really come into play. TIN A opened the majority events during the performance year for this patient. Therefore, they're going to receive attribution at both the TIN NPI level and the TIN level. TIN B does not have any plurality here, so they will only receive attribution at the TIN level. But if you take a look, that only applies to the first 10 months of the candidate 3 event. the last 3 months are open to attribution for TIN B because it does extend into the next performance year. So depending on whether other candidate events are open and who has plurality during that time, TIN B may very well be attributed for those last 3 beneficiary months. Next slide. So attribution is done differently for other measures. Let's take a look at MSPB first. In this example, which is for medical MSDRG, it attributes first to the TIN that bills at least 30% of the E&Ms that are applicable to the measure during the inpatient stay. And then if an NPI under that same TIN bills at least one E&M service, then that TIN NPI combination will also be attributed. So here we see an inpatient admission, and the patient ended up seeing 8 different clinicians during their episode. Of those 8 clinicians, they were split out into 4 different TINs. So only one of the TINs billed over the 30% threshold, which is going to be TIN D in this example. Therefore, only TIN D is going to qualify to be attributed to the episode because they've billed the 56%. Now, if you look at the clinicians, each of the clinicians at TIN D billed at least one E&M code, so all of them will get attributed to the episode. The clinicians at the other TINs, they also billed an E&M code, but because their overseeing TIN did not have the 30% advantage, they do not get attributed. And next slide. Now, surgical DRG works just a little bit differently. The TIN and NPI TIN combination are attributed at their respective levels if they both bill a relevant CPT HCPCS code that is related to a surgical DRG. And what our example shows here is that TIN A is the only TIN of the 3 that billed a relevant code, and that only clinician 1 in TIN A billed a relevant code. So therefore, only those 2 will be attributed the episode. If the other TINs had billed a code, then their clinicians would also be eligible, but only if they had also billed a code under the TIN NPI. Next slide. Now, episodic care attribution will be specific to the different measures. Here we took an example of the attribution method for routine cataract removal with Iowa implant. So basically, once the trigger code is identified, there are steps to designate the main clinician and then to designate an assistant clinician if applicable. And then once that is done, then the episode is attributed to the main or assistant clinician at the NPI TIN level, and the TIN level attribution is given to the TIN associated with the attributed NPI. And that is going to cover the basics of cost, but before Katie takes over, we are going to have another poll. Please take a moment to answer the question when it appears. Okay, next slide, please. And Katie Buckholz will now guide you through the cost category calculation basics and methodology. She'll also be providing you a real-life case study and then some tips and tricks for maximizing your cost score. Katie, it's all back to you.
All right, everybody. Good to talk with you again. So hopefully we haven't put you to sleep just yet. So what we're going to do is we're going to continue on with calculation basics. So first of all, let's talk about the weight of the cost category as it pertains to the final score for traditional MIPS reporting. Now this spring, CMS announced that due to the COVID-19 pandemic, their analysis of the 2020 performance year data, they didn't believe that they could reliably calculate scores for the cost measures that would adequately capture and reflect the performance of MIPS eligible clinicians. So what that means is when you see your 2020 final scores that are due out later this summer, the cost category will have a 0% weight. Now, that is so far not the case for 2021. So for this performance year, the cost category contributes 20% to the final score. And then beginning in 2022, as we mentioned earlier, the cost category will have the same weight as the quality category at 30% each. So
Katie,
now for,
sorry, Katie, could you please go ahead and move your slide?
yes.
Thank you.
So now for more fun, let's continue with the cost category calculation basics. So we're going to take a look inside the exciting world of methodology. So now as we get into methodology, have you ever heard of the term comparing apples to oranges? So for the cost category methodology, this is where CMS tries to make apples, oranges, kiwis, raspberries, and watermelons all equal for mathematical and comparison purposes. So we're going to review the TPCC. So the purpose, if you remember, is to assess the overall cost of care delivered to a Medicare patient with a focus on primary care received. So we see here that we start off with identifying the candidate event. And this is basically the start of a primary care relationship between a clinician and a Medicare patient. Now, to open the event, you need to have two different billing situations. One is for the E&M primary care service, which includes like codes like outpatient settings, physician offices, etc. And then another second billing for a primary care service, which occurs within 3 days or within 90 days, depending on which code is used on the claim. Now, the second billed service is the one that actually opens the risk window. So then we come into where the specialty exclusions come into play. TPCC has what is called a step 2 physician in their methodology. So this means that if you are a specialist that is not excluded, then you may end up with the plurality or majority of candidate events for a patient. So the way this happens is if a patient sees a primary care doctor once a year, but sees a specialist many times a year, that the primary care doctor is attributed this measure. So that way, if the specialist is not excluded, then they may end up getting the total cost of care for the year attributed to them, which means that even the cost that they had no control over, like the primary care visit costs, are calculated into their score. So that's why we have this kind of this step 2 in identifying the candidate events. All right, so second part is where we identify and apply exclusions, and then the risk windows are constructed. All right, moving on here, we attribute the beneficiary months to the TIN and the TIN NPI level. We calculate the payment standardized monthly observed costs, and then finally the risk adjust monthly costs. All right, now by this point, a risk score is generated and the risk adjusted total is calculated. And then the specialty adjustment monthly cost is performed. And then we have our calculation, which is done by dividing each TIN and TIN NPI's risk adjusted monthly cost by the specialty adjustment factor multiplied by the observed cost across the total population of beneficiary months where the risk window overlaps with the performance year. All right, let's go on to our next one here, the Medicare spending per beneficiary clinician. So remember, this purpose is to assess the cost of care for services related to qualifying inpatient hospital stays, so immediately prior to, during, and after for a Medicare patient. So what we do is we define and trigger the episode, then it gets attributed to the clinicians. Now, episodes with MSDRGs, so a Medicare Severity Diagnosis Related Group, those are attributed to first the TIN that bills at least 30% of inpatient E&M services during the index admission, and 2, any TIN NPI who billed at least one E&M service that was used to meet the 30% threshold for the TIN. The episodes with surgical MSDRGs are attributed to the TIN and TIN NPI that provided the main procedure for the index admission. Next, we exclude clinically unrelated services. We work on excluding episodes. And then at the very end, we use the risk adjustment to estimate the episode cost. Finally, time to calculate. This is done by calculating the ratio of standardized observed episode costs to Winsorized expected episode costs, and then multiplying the average of this cost ratio across episodes for each TIN NPI or TIN by the national average observed episode cost. All right, now for the majority of our audience, I know we have a lot of folks who work with or are ophthalmologists and optometrists. So this is where the cost cataract episodic measure comes into play, is in the episode-based measured methodology. So for this, remember we have 13 procedural episode-based measures and 5 acute inpatient medical condition episode-based measures for a total of 18 possible measures. And this one is more focused on the specialty providers. All right. So when we get into this, we start off, trying to create everything equal. So we get the trigger and we define the episode, and it relies on billing codes that will open or trigger, if you will, an episode. And then the pre and post trigger period length of episode varies by measure. So for the cataract episodic cost measure, you have a pre-trigger window of 60 days prior to the cataract surgery. And then for the post-trigger window, you have 90 days after the cataract surgery. So CMS will look at that as an episode. Then we move to attribution. So this is, in our example for cataract episodic cost, this is any clinician who bills a trigger procedural code. So it's not necessarily the cataract surgeon. It could be, say, an optometrist or a retinologist who sees the patient within that time frame. All right, the third step here is to assign costs to the episode and calculate the standardized episode observed cost. These are standardized to account for differences in Medicare payments and are unrelated to the care provided. All right, next up, we have exclude the episodes. So this removes unique patient groups in cases where it may be impractical or unfair to compare the cost of caring for those patients to the cost of caring for the cohort at large. Next up, we risk adjust the cost to calculate expected episode costs. And then finally, calculate the measure score. So this little scary slide here, I promise you don't need a advanced degree in mathematics. What it basically does is it shows that we calculate the ratio of standardized observed episode costs to the expected episode costs. That gets multiplied by the average cost ratio across episodes for each TIN NPI or TIN by the national average episode cost. As a side note, if you're feeling overwhelmed by any of this, feel free to sign up for CQE services because we will be happy to help you and take this off your plate. So just a shameless ad there. All right. So that is just for one episode. So in this slide, you can start to see where you have multiple episodes. Now, in the case of the cataract episodic cost removal, any single patient could technically have 2 episodes for that measure. So let's say the right eye is done during the performance year and then the left eye is done during the performance year. That patient could then qualify for 2 separate episodes. All right, so let's start to put all of this craziness together. This is a case study, and this is actually an actual situation that we found occurred when I was auditing one of my clients. So here's the situation. A cataract surgeon performs a standard cataract surgery with the CPT code 66984. And this was done on the right eye of a patient who has Medicare insurance. Now, 70 days prior to surgery, the physician performs a complete eye examination. Now, in addition to the presence of a visually significant cataract in the right eye, diabetic retinopathy is charted as well. Now, surgery is performed, and then following the standard cataract surgery at the 1-week post-op visit, the cataract surgeon notes cystoid macular edema in the surgery eye. So then for this, the surgeon orders a macula OCT of the surgery eye. All right, so that was the situation. Now, what went wrong as far as cost attribution? So was the timing and coding timing. So for the cataract removal episodic cost measure, the episode is triggered and opens with the code of 66984. Now from that date, there is a 60-day pre-trigger period and a 90-day post-trigger period. So what happened is because the examination where the diabetic retinopathy was coded along with the visually significant cataract, it occurred outside of that 60-day pre-trigger window. It wasn't counted when CMS was looking at the trigger date. So if the examination and its coding would have occurred within the 60-day pre-trigger window, the patient would then have been excluded from the episodic cost measure due to the diabetic retinopathy code, and the expense, the additional expense of the macula OCT would not have been attributed to the cataract surgeon. All right, and we'll move on here, and we're going to go into some tips and tricks. All right, so one of the tips is to do what's called an internal audit. Right at the moment, what's available to you on your quality payment program login is your 2019 performance feedback. So if you need to create a login for your tax ID number, what you do is you go to the quality payment program website and you can register for an account. Once you register, you're approved, you can log in and check the patient list of patients who were attributed to the clinician for certain cost measures. Now, so once you can download that patient list. Once you do, you're also going to want to download the measure-specific codes list. Now, it's listed on our resources slide at the end of the slide deck. And what you do is you use this as kind of a key when you're analyzing the patient list from 2019. As a side note, when you're looking at that patient list, CMS has not deduplicated the codes on that list. Now, deduplicated, had to look up what that meant when CMS responded with my concern that there were duplicates on this list. It means that you will occasionally see duplicate codes on your patient lists. CMS did not, however, duplicate the codes in their calculation. So don't be alarmed when you see duplicates on the patient list. That list just didn't have the duplicates removed. So don't panic when you see those. Now, as you're looking at this measure list, and again, we're using the cataract episodic cost removal as the example. Your coding accuracy will be discovered during this stage of the analysis. Now, using the measure-specific codes list, what you can do is you can use the worksheet tabs that you'll see when you download it down at the bottom here, and you can navigate through the document using that. Now, using specifically the exclusion details tab, this little green guy right here, use this to analyze your comorbidities. So based on your analysis, when you're looking at your patient list in conjunction with this measure codes list, you may decide to make adjustments to your patient care or clinical processes. For example, for this measure, strongly consider performing a cataract evaluation within the 60-day window prior to cataract surgery. As we saw in our case study, that way comorbidities such as diabetic retinopathy that are coded during the exam, that will exclude patients from unnecessarily contributing to a lower cost performance score. All right, next slide here. We also want to think about referral relationships. So we see in the overview tab of when you download this document, the overview tab has the timing, so that pre-trigger and post-trigger period. So when we remember our case study example, the timing of your codes matter according to these trigger windows. Now we also want to be aware of this tab down here called service assignments. Now, in this example of the cataract episodic cost measure, other physician services can be attributed to the cataract surgeon's cost score. So things that might be performed by an optometrist or a retinologist or another specialist. If they submit codes that appear under the service assignment, it could affect the cataract surgeon's cost score. So things such as the anesthesia used by the anesthesiologist, or punctal plug placement, or retinal imaging. Those things, if they occur during those trigger windows, could also affect the cataract surgeon's score in the cost category. So this is where, especially with co-management, it becomes very important to analyze the patient lists in the cost category and see where the attributions are occurring. All right. Another tip is to think about the implications of overlapping diagnosis codes between the cost category and the quality category. So going back to our example, where the cataract surgeon coded for diabetic retinopathy. Now, diabetic retinopathy would exclude the patient if coded during that 60-day pre-surgery window. It would exclude the patient from the cost category. However, by coding for diabetic retinopathy, the surgeon now needs to think about measure 117 of the quality category. So, and the other measure. So we have the diabetic eye examination measure and the diabetic retinopathy communication letter measure. So those measures will also have to be considered to be met when we're adjusting our accuracy of coding. So if you think of a nice little poem, and I wrote this especially for you guys, hopefully you're waking up about now. So if you see it, you code it and you report it. So if you code it, you're responsible for meeting the measure across the various categories. So just remember, if you see it, you code it, you report it, you're responsible for it. And now I'll turn it over to Laura.
Thank you, Katie. Before we wrap up our presentation, we would appreciate your input on one final poll. Please respond, and then we'll be back in a moment with some resource information and comments. Also, be sure to submit any questions you may have in the question window on the control panel. We'll be sure to respond to those in a separate follow-up. Okay, and go ahead and move on to the next slide, Katie. Okay, thank you once again, everybody, for your feedback. We really do appreciate it. Here on this slide, you will find the resources we've referenced throughout the program, and you will need to review the cost, use these resources to review the cost measures in full detail. We hope that today's presentation will make understanding this documentation a little bit easier. We will give everybody a few moments before we close to make sure we have received all of the questions from our audience. In the meantime, we have recorded this presentation, and we will be making it available very soon, along with the answers to any questions that we've received. Listen, we will also be holding another webinar in August. Join Megan Fries and Jenny Jaquez as they review Cinderella improvement activities, and where you can find out if one of the lesser known improvement activities is a good fit for your practice. So once again, thank you so much to everybody attending today's webinar, Decoding the Cost Category. We know your time is extremely valuable and we do appreciate you sharing it with us. Have a great afternoon.